Hi everyone, it's Dr. Crad. Today I have a really interesting case for you. This patient is about 50 years old and underwent refractive lens exchange to get rid of her reading glasses. She had surgery elsewhere about 5 to 6 months ago with a skilled surgeon. Here is her eye after surgery. The PanOptix lens looks beautiful. It's centered perfectly. She even had a YAG capsulotomy, so the optical clarity is pristine. But in this case, looks are deceiving. This patient is miserable. She feels debilitated due to her poor vision. She says everything is double with that eye and that she has a dense shadow covering half of her visual field. This is her vision, and here is her visual field. This is the type of visual field you see when someone has a stroke. However, it's only in one eye. So a thorough exam was performed, including color vision, a fundus exam, an OCT of the macula and optic nerve, even an MRI of the brain, all normal. She had multiple opinions, including at a local university eye clinic where visual evoked potential testing and multifocal ERG were performed, all normal, except this reproducible hemifield loss of vision. So what's causing this loss of peripheral vision? Could it really be from negative dysphotopsia? We wouldn't expect negative dysphotopsia to cause such a dense visual field loss that approaches the central vision. It's usually very peripheral. This is truly unbelievable. But as rare as it is, the patient needs help. So what can we offer her? The posterior capsule is already open. The two options I considered were either, one, reposition the optic of the PanOptix lens in a reverse optic capture configuration with the optic of the lens anterior to the capsular rhexis margin. My thought is that her negative dysphotopsia should decrease, but she'll still have the presbyopia correction that she initially wanted with the multifocal lens. Number two, the second option is to remove her PanOptix lens and then implant a different lens with better optical quality and lower likelihood of negative dysphotopsia. Option one would be my preferred option if her best corrected visual acuity was good and her only complaint was this negative dysphotopsia on the side. But since her vision quality was extremely poor, I wasn't confident that a repositioned PanOptix would make her happy. She would likely need another surgery afterwards to remove the lens. I would also consider placing another presbyopia correcting lens in her bag if her YAG capsulotomy was smaller. Sometimes you can place another single piece lens in the bag even with an open capsule so long as the YAG capsulotomy was small, not bigger than 3 or 4 millimeters, but also that enough time has passed for it to fibrose so it doesn't spread open. However, her YAG capsulotomy was about 5 millimeters and I didn't think her bag would support a single piece lens. Also, most multifocal lenses have a square edge that would also induce more negative dysphotopsias. These factors considered, and since she stated that she would be okay with using reading glasses so long as she can go back to having good quality vision, this led me to choose the option of exchanging her lens implant for a monofocal silicone lens implant with a round edge. Options I considered were the Light Adjustable Lens Plus and the Bausch & Lomb Li61 AO. Given the fact that her symptoms were so unusual, I let her know that I'm not 100% certain that her symptoms would be completely resolved, but that it's probable that either of these options should help. And she was very understanding. Here is the surgical video. After creating a paracentesis, I irrigate the anterior chamber with some preservative-free lidocaine and then inflate the anterior chamber with viscoelastic. After that, I'm going to create a temporal incision. I'm not going to use the previous incision. I don't like the previous incision. Even though it was done with femtosecond laser and was perfectly shaped, it's too anterior. I want to create an incision more posterior and behind the previous incision. And I'm going to expand it a little bit because when I cut out this lens, I want to make sure that it comes out relatively easily. Here I have a sharp tip spatula and I'm going to raise the capsular rhexis edge, and after I separate the anterior rhexis from the IOL, I'm going to use a blunt spatula and do the same thing, followed by instilling viscoelastic to open the capsular fornix and separate the haptic from the capsular bag. Throughout the procedure, we need to make sure that we keep the vitreous posteriorly and separate from the anterior part of the eye. The viscoelastic will act like a wall, a barrier. I'm using a Conner wand to lift the optic anteriorly to see if I can free the haptic, but it's socked into place. So I'm going to place more viscoelastic near the haptic, and then I'm going to use a Sinskey hook to sweep along the haptic to see if I can free the terminal bulb of the haptic. And after a couple of sweeps, it works. Now I'm going to go after the trailing haptic. So I'm going to inject more viscoelastic, first to tamponade the vitreous posteriorly, and then I'm going to try to rotate the IOL anteriorly. And the trailing haptic seems to free itself fairly easily. Now I'm positioning the entire lens in the anterior chamber, getting ready to cut it. But again, I'm going to use viscoelastic to create space both in front of and behind the IOL. I keep replenishing to keep the vitreous posteriorly, and I'm watching the anterior capsulorhexis edge to make sure that it stays round. After that, I'll use the MST IOL graspers to hold the optic of the lens, and the MST IOL cutters to cut the lens in half. You could do a twist and remove technique, but the posterior capsule is open, and so I would rather just cut the lens in half. It's very controlled and nothing is twisting around in the eye. The PanOptix lens is a hydrophobic acrylic lens, so it cuts in half very easily. After the lens is bisected, I'm going to use some forceps and pull out each half one at a time while protecting the cornea with my second instrument. Now I'm going for the second one, and both halves of the IOL come out very easily. Next, I'm going to create space in the ciliary sulcus. I'm going to tamponade any vitreous posteriorly. The capsulorhexis is nice and round. And I'm going to put in a B&L Li61AO lens. This lens is a 3-piece lens, and it's known to have very low rate of negative dysphotopsia. And so I'm going to place the leading haptic in the ciliary sulcus. I like this injector. The lens comes out fairly planar, so it's very easy to insert. After the leading haptic is in the ciliary sulcus, I'm going to use a forceps to grasp the trailing haptic and position it also into the ciliary sulcus. We have the choice to leave the IOL optic in the ciliary sulcus because that has the lowest rate of negative dysphotopsia, but it's also less centered. So the advantage of capturing the IOL in the bag will allow for better centration. This is a young patient, and I decide to capture the optic given that there's a low rate of negative dysphotopsia with this silicone IOL by B&L. And so here I'm just double checking that it's captured in the capsulorhexis and it's beautifully centered. In the effort to maintain the anterior chamber, I'm irrigating the viscoelastic out, also hydrating my incisions early so that I have better chamber stability. After irrigating out most of the viscoelastic, I inject some myostat in the anterior chamber, and then I'm going to test the anterior chamber with some dilute triamcinolone to see if I have any vitreous prolapsing forward. And it looks like I have a subincisional vitreous strand, and so I'm going to create another paracentesis to do a bimanual anterior vitrectomy to remove this. We almost got away with not needing a vitrectomy, but it's always best if you see a vitreous strand to vitrectomize it. After doing that, the posterior part slips back behind the lens, and there's just this tiny segment of vitreous within the incision. I will remove this vitreous segment, and then I will hydrate my incisions. The pupil stays nice and round, and that concludes the surgery. Here is the patient after surgery. Their lens implant looks perfectly centered, pupil is nice and round. Fortunately, she was doing well. The day after surgery, I could not wait to ask how the patient was doing. I was so curious that I wanted to repeat the visual field testing immediately. And here is the patient's visual field. Amazing. She did not notice any shadow anymore, and the optic of the lens implant was captured posterior to the capsulorhexis margin for optimum centration. So the square edge and the lens material are what truly eliminated the patient's negative dysphotopsia. This is the patient's vision a week after surgery. I don't know if she was happier or me.
2 weeks later.
Hey guys, I have to interrupt my own video right now because unfortunately the patient let me know that her symptoms have returned. Even though 1 day and 1 week after surgery she was not noticing the peripheral shadowing, she said that around 2 weeks after surgery she noticed it come back. Although her vision quality is still much better, she is having the negative dysphotopsia in the periphery of her vision. And when I took the visual field again, it shows up. And in trying to determine why would it come back after 2 weeks, she just had 2 weeks of healing. It's not like the lens moved positions, her cornea is healing. But there are two things that come to mind. One is the way the lens implant was positioned, captured inside the anterior capsule. That is for centration. However, there is a higher rate of negative dysphotopsia when the lens implant optic is posterior to the capsulorhexis. So one thing could be that optic position. So if we go into surgery and prolapse it anterior to the rhexis, it would sit in the ciliary sulcus. That could decrease her negative dysphotopsia. The second thing that I wonder is, could it be related to that corneal incision? That temporal corneal incision by the femtosecond laser has some scarring around it, and it's a little bit anterior. It's not common to cause negative dysphotopsia, but you just always have to wonder, what if it could? And so that's the other thing I have in the back of my mind. I was just wondering if when I created the incision posterior to it, did it soften the edges or at least change the optics of the cornea so it wasn't noticeable? The most likely cause of the negative dysphotopsia is the optic position, but you just got to wonder if it could be something else as well. So we're going to go back and we're going to try to fix this for the patient. The patient is super understanding, of course, because we did talk about the possibility of her needing multiple procedures to try to fix this. So I will update you as I learn more. I reopen my paracentesis and my main incision with a Sinskey hook, and then I irrigate the anterior chamber with preservative-free lidocaine, and then fill the anterior chamber with viscoelastic. In this procedure, we're going to uncapture the optic from the capsulorhexis. So I'll use a Connor wand to lift the optic anteriorly from one side, and then I'll do the same on the other side. Since the posterior capsule is open, we have to be careful with vitreous prolapse. I'm going to gently irrigate the viscoelastic out of the eye, as well as instill myostat to bring down the pupil. As I do so, I feel that the IOL is not centering perfectly, and I suspect vitreous coming subincisionally. So I'm going to perform an anterior vitrectomy. I'm performing vitrectomy posterior to the IOL, and I want to perform this thoroughly, so I spend at least a few minutes doing this to make sure that there's no more vitreous prolapse. I am fast forwarding in this video, however. The lens implant seems to settle much better after the vitreous prolapse has been taken care of. Since I want to keep the anterior chamber formed, prior to removing the irrigation handpiece, I will hydrate my incisions, making sure my main incision is sealed prior to removing the irrigation from the eye. Next, I'm going to check for vitreous in the anterior chamber using Triessence, and the AC is clear. Finally, I'm going to check to make sure all the incisions are watertight and that the eye pressure is appropriate. And now I'm just going to hope that the patient's symptoms improve. Here is the patient day 1 after surgery. Their pupil is still constricted from the myostat from the day before. I ask the patient if their symptoms are any better. The patient says they can't really tell yet because their vision is still blurry, but when I do a field, there is still some temporal defect. Negative dysphotopsia is more prominent when the pupil is constricted, so I bring them a few days later to see how they're doing after the pupil normalizes. And they're doing much better. The patient doesn't notice the negative dysphotopsia, and it doesn't show up on the field. But will it come back? I want to monitor this patient closely. This patient is very nice, and I'm really hoping she does well. If the negative dysphotopsia does come back, What would your next steps be? I'm interested to hear the opinions of all the surgeons around the world, so leave your opinions in the comments below. Thank you so much for watching. I'll catch you on the next one. Peace.